Morning, everyone. Thank you for making it. It's cold this morning. I want to thank Dr. Robitaille for making the journey to Dalhousie. She claimed that this is not too cold for her, from her back. I'm used to this, but we'll test you today. Dr. Ramirez conducting the diploma.
Okay, good morning, everybody. Thank you for being here, and thank you, Dr. Robitaille, for accepting our invitation. I've got my little notes here to introduce Dr. Robitaille. I'll make it a little bit shorter because she's got an extensive CV, just for the sake of time. But Dr. Robitaille joins us from Halifax, as you heard. And there's so many impressive things, but I'm going to pick out a few things if that's okay. So she's a professor of ophthalmology at Dalhousie, but she's also cross-appointment in the departments of pediatrics, pathology, and genetics as associate professor as well. So very, very, very broad. And she's one of the only few people I know that has 3 different fellowships. It's impressive because I did 2 after all that stuff. But so from University of Iowa, she's done pediatric ophthalmology business, and also from Iowa, she's done neuro-ophthalmology, and then she went on to Johns Hopkins to do genetics. So that's 3 fellowships. And you can imagine with that pedigree what you end up doing. So she is, again, one of the people I know who's discovered not just one gene, and your gene is important when you get published in genetics and genetics. So she discovered the Frizzled 4 gene for FEVR, and then that was in and out. So then she discovered the KIF11 variation as well. So multiple publications, I think too many to count. And finally, she's PI or co-PI in multi-million-dollar grants from CIHR and a lot of funding organizations. So I think that's a good summary to explain why she's our visiting professor from Dalhousie, and we're very proud to have you. And I know we might be running a couple of minutes late, so I'll leave you to have more time for the talk. Okay, thank you for being here. Yes.
Thank you for this kind introduction. It's a pleasure to be here amongst friends, and I am grateful for actually having been invited and having the opportunity to talk to you about familial exudative visceral retinopathy, the topic that's been the major topic of my research throughout my career. So I'll focus on talking about FEVR, but I'll talk also about some related developmental retinal vascular disorders, and then I'll intersperse some of the contributions we've made to the literature over the past 3 decades. So I have to disclose that I do have a financial disclosure. I'm going to actually talk about treatment for FEVR, for which we have a patent.
My apologies.
Oh, it's okay. So you guys all got the objectives of the talk, so I can skip that slide.
So I might have to restart this. My apologies.
Is that true? So you take 30 seconds to review that slide.
I see it. It's so long, I forget. Yeah,
Email never works.
Do you guys want to have this period over there?
Well, it's just as long as you see her notes.
Okay, awesome.
On the desktop. I want slides to tell you a bit about the history. So it was first described fever in 1969 in a paper by Criswick and Skeppens, and then further elaborated from actually authors in London, Ontario, who described the large pedigree. It was the first pedigree described for this disease, and the mode of inheritance in that particular pedigree was autosomal dominant. This is the same pedigree that I used 15 years later or so to identify the first gene for autosomal dominant fever with Frizzled 4 gene. So works.
It's out there.
Thank you. So they read those. And so Glenn Oliver, a little later described the fluorescein angiographic findings in the fever. And one of the things they stressed was, is this a pointer? Oh no, the mouse, right? Is there people online? Is this a pointer?
What's that?
Is this a pointer? Yeah, there's a pointer. Okay, but.
Sandra, I think online they're not seeing the presentation.
Oh,
You need to share.
so there's no
Oh,
presentation.
yes, you'll have to share it again if you were sharing that, yes.
Oh, right. I like the screen, that looks slimmer.
Can somebody online say they can hear the
And again, we lost the note.
Rose I speak?
It's okay.
Is the volume and everything else okay?
We don't have to. We might just have to mirror.
It's not very.
It's okay.
Okay, can-
She's got it.
Can you get him to come?
She's got it.
Yeah, presentation is on here.
You're not reflecting here.
It's there.
Oh, wait, no, wait,
There you
no.
go.
So now it's.
Yeah, see, they're seeing that.
Yeah, so we need to remove that.
Sorry, remove it.
Because that's gonna be distracting.
So let's see here.
Oh, exactly.
Maybe we can mirror them exactly.
Yeah, this is exactly. Let's use how we.
How much we see it there?
I retired from AV stuff.
They're showing? Oh, no, it's working.
And then we get rid of it.
Okay.
And do you want me to get rid of that?
No, it's good. You want to try, does it, can you advance? Okay, try now. There you go.
Sweet.
Okay, so.
So it works, they can hear me, they can see, we can see, you can hear me. Awesome. So the authors of those first few papers stressed that, oh, there it is. And do you see the mouse moving here? No. So there's no way for me to, right? There's no way for me to point so that the people online see what I'm pointing to.
There's a pointer on the,
On this, but online, because but online, even if I'm using the mouse, they're not gonna see it. It's okay.
no,
That's okay. So they wrote, we stress that there's a similarity between familial exudative vitreoretinopathy and retrolental fibroplasia, which was the term used for end-stage retinopathy of prematurity initially. And I'll show you a picture of actually what that looks like in fever and how identical it is to these descriptions of retrolental fibroplasia or end-stage ROP. So in its mildest form, fever is manifests a failure of completion of retinal vascularization to the aura, and in these situations, there are no symptoms. This so happens to be the grandmother of a child who has the typical appearance of retrolental fibroplasia, that pedigree that was originally described by Gowan Oliver. So then at the next phase, at the leading edge of existing blood vessels, just like in retinopathy of prematurity, you can get neovascularization and fibrovascular proliferation that causes at first macular dragging, retina dragging, and then eventually retina detachment. And in these patients, there will be some vision loss as a result of that. There may or may not be some posterior vascular anomalies with leakage. And in the severe form, you can have a macular fold extending through the macula or even a complete retinal detachment. And this is the granddaughter of the other patient I showed you. So it highlights the variability found in these pedigrees. There's a staging system that was revised a number of times until the 2014, that's the latest one, whereby they grade the degree of severity in stages 1 to 5, with either A or B being with or without exudates or leakage. So in stage 1, that would be for patients who have avascular peripheral retina or anomalous intraretinal vascularization. Stage 2 would be avascular retinal periphery with extra retinal vascularization. 4 would be extra macular retinal detachment. That's 3 and 4 with the macula involving retinal detachment, and 5 with total retina detachment, and somewhat some similarities to the staging found in ROP. There are other vascular features that are not accounted for in these stages of degrees of severity that include aberrant circumferential peripheral vessels, venous and arterial tortuosity, late phase disc leakage, central and peripheral telangiectasias, capillary anomalies in agenesis, venous to venous shunting. There's a picture there on top. Delayed arterial venous transit, delayed or absent choroidal perfusion, macular anomalies with the macrovasculature. And in the bottom one, you can see the vessels taking on a circumferential course anomalously with the periphery of that area being avascular. So the incidence is, the exact incidence is unknown. It was said to be rare. In the original papers for gene discovery, we were using an incidence of 1 in 10,000, but it's probably more common than that. And then in 2020, there was a publication that suggests the prevalence may be as high as 0.45% in a multi-center trial of almost 63,000 newborns with a gestational age of at least 32 weeks and a birth weight of at least 2,000 grams, who had eye examinations using wide field digital imaging within 28 days of birth. Whether these are all fever or not, at least the incidence may be higher than we think. It's somewhere in between these two extremes. In general, symptoms, if they do appear, start early in childhood or teenage years, and the more severe the disease at presentation, because you're born with it, the earlier the complications will be. But also you may see some slow progression over time. There's no treatment for the disease itself to reverse the disease itself, but one can treat the complications as they emerge. And so surveillance is important, and early surveillance even more so where the complications are the most significant. This is the pedigree that I was able to extend from the Go and Oliver paper. I had to go back and start over, and it ended up identifying 436 patients in this 8-generation pedigree. There's now 10 generations, but I don't have the update on that. In this particular pedigree, I was able to obtain clinical data on 32 patients, and of the 32 patients, 16% were legally blind, and that represented 33% of the eyes that were blind, and 14% of eyes had no light perception, and one patient had no light perception in both eyes. And then visual impairment actually is not that common. They somehow are either okay or not. And so driving vision is present in about 60% of eyes and 78% of patients. So when you look at the literature, that fits with what's been reported, where the blindness is found in about 20 to 40% of affected eyes, or 12 to 17% of individuals. Chen and colleagues looked at 355 children at presentation and follow-up. And in 18% presented with stage 0 to 1, and of those, most remained stable for over 2 to 10 years follow-up. 20% presented with stage 2 to 3. A third of those needed intervention to stabilize the disease in 90%. But if you had stage 4 or 5, which was present in 61% of the children, 56% were deemed untreatable, or treatment was abandoned due to poor prognosis. But there was a small subgroup, 38% of those who were operated did have a favorable response. But in terms of what that means in terms of visual acuity, only 20% presented with stage 4 or 5 ended up with better than legal blindness. So it's a significant burden of disease in those patients. The inheritance is most often autosomal dominant, followed by X-linked recessive and autosomal recessive. And I'll just have a parenthesis about X-linked dominant a little later. The variability, as I showed you, can be quite variable. That's not just our pedigree, but most pedigrees that have been reported show the same kind of variability. But the penetrance is almost complete if you add a fluorescein angiogram. If you don't see any features, you do need the fluorescein angiogram to highlight subtle changes that you would miss otherwise. So I'm going to go through a timeline of when the genes were identified. So it's not that long ago. I think most of you were born. And the first gene that was identified was the NDP gene that encodes for Norrin that causes Norrie disease. That was identified for X-linked recessive fever in 1993. Then we identified the first gene for autosomal dominant fever in 2002. And a couple of years later, LRP5 was identified as a cause of autosomal dominant fever. And then a little later as a cause of recessive fever. And then 6 years later, T-span12 was reported as a cause of autosomal dominant fever. And a couple of years later as a rare cause of autosomal recessive fever. And then ZNF408, this report in 2013 identified only 2 variants. And to this day, there are only 2 variants that have been reported in this gene. There is some good functional evidence that to support this as a fever gene, but it's extremely rare. It's the most rare of the fever genes. And then in 2016 was the last gene identified, so no further genes for the past decade. That's CTNNB1 that causes autosomal dominant fever in some patients, and in some others, actually syndromic fever-like. So that was the last fever gene discovered. In 2014, we reported KIF11 as a potential cause of fever with significant overlap, and in some patients, such subtle systemic features that for a decade, it was considered one of the official fever genes, but OMIM removed it as one of the recognized fever genes because pretty much everybody has microcephaly at a minimum, in addition to the ocular features. So there is nothing really to differentiate the genetic cause in autosomal dominant fever between all the different fever genes. However, there is a little bit of phenotype-genotype correlations that we can draw from what's been reported. Biallelic forms tend to have greater disease severity, and LRP5 variants have been associated with an increased risk of bone fracture. There was one pedigree with 4 out of 6 members who had multiple bone fractures in childhood and osteoporosis, and 60% on average bone mineral density compared with age-matched controls. In addition, biallelic LRP5 variants were found to confer a 3.5 roughly greater risk of severe disease compared to heterozygous autosomal dominant fever. Biallelic variants in LRP5 may cause osteoporosis pseudoglioma syndrome, or OPPG, which is characterized by microcephaly and severe bone demineralization, and so many bone fractures early on in life and severe form of fever. And then there are other cases with biallelic variants in LRP5 that cause only microcephaly and fever. So there's quite a range. But interestingly, there's no report that talks about eye examinations in OPPG carriers, although they have been studied for bone densitometry and shown to have reduced bone density. There's no study either that looks at systematic bone density testing in fever patients with variants in LRP5. So it's unclear whether all patients with LRP5 should undergo bone densitometry testing. I tend to send them, but I also tend to counsel the patients if there's a bone fracture, you should probably get that checked. I'm not sure how that would change, and so I think perhaps that's probably why it hasn't been studied. And then certainly for OPPG carriers, there should be a role for systemic eye examinations. If we don't have a pedigree like that in Halifax, it's super rare. But if I was to be asked by our genetics team whether I would want to see the parents, I would say, yeah, definitely. Not just because I'm interested in the disease, but I think there's a role for surveillance. Especially for an ultra rare disease, you really need to do due diligence. And so that's for LRP5. For frizzled 4, we identified actually a new syndrome with biallelic variants in frizzled 4, and that was a patient of Alex Levin's who Ben Myers was his medical student who reported the clinical features in this disease, and our postdoc Sarah did the functional work, and she was able to demonstrate that in the cellular assay, introducing both variants, transfecting both variants in the cell assay reduced significantly more intracellular signaling than either variant transfected along each of the assays. And so that correlated with what was seen phenotypically with the top image showing the child at a very young age, just a few months of age. I think she was 2 or 3 months, and she already had bilateral retinal detachments. And then the parents showed only mild features with some peripheral avascular retina and some mild vascular changes in keeping with the disease. And there were finally one pedigree of digenic inheritance, whereby those who had both a frizzled 4 and an LRP5 variant had more severe disease than the relatives who had either variant, just one of the two. So I'm going to switch gears a bit, and we're going to move on to Nori. And if you notice the baby's eyes, it does look a little bit like the retrolental fibroplasia that we talked about earlier. And the slide on the left, and the image on the left would show that what would be considered moderate disease. On the right would be severe and moderate. And it was first described in 1905 by Fernandez, who described the congenital the features in 2 brothers from Cuba who had congenital bilateral retinal detachments, but nothing else was mentioned. Nori in 1927 reported the causes of blindness in Denmark and described 2 families with 7 affected members. And again, that was all that was described. And credit goes to Mette Warburg, who named the condition Nori disease after Gordon Nori, who was a former consultant ophthalmologist at the Institute for the Blind in Copenhagen. And this is the same role that she took on after Gordon Nori. She reviewed the literature and identified 106 individuals from 16 families from all over the world. And so it highlighted that there wasn't a single founder population. And it also brought out its impact on certain communities that are more isolated. And this is reflected by the fact that it was called Episcopi blindness in Cyprus, in a small town called Episcopi. She gave the first detailed description that we now use to diagnose Nori disease. And so that includes bilateral retinal dysplasia and detachment that are present at birth or shortly after, and sometimes before birth. Progressive cognitive delays and dementia, psychosis in about 2/3, and variable hearing loss in this, that starts in the 2nd or 3rd decades in 25 to 40%. So the ophthalmologist will be the first to see the manifestations of this disease, and then the other features may show up later. And so in terms of counseling these families, once you identify the variant in Nori, the Nori disease gene, there are actually some phenotype-genotype correlations. It's the same variant tends to cause similar disease, similar ocular disease severity, which is either moderate or severe, in contrast to the autosomal dominant forms, in which one pedigree may have quite a range of degrees of severity. The position of the missense variants within the functional domains predicts disease severity, and large deletions, inversions, insertions, duplications, splice size variants tend to cause more severe disease. Variants in untranslated regions cause moderate retinopathy. So you notice that none of the males who have Nori disease or variants in the Nori disease gene actually have mild disease. Hearing loss and intellectual disability is almost exclusively in those with severe retinopathy. So there's a bit of information that can be given to the families with the genetic counseling. When the Nori disease gene was identified as a cause of fever, nobody really knew through which mechanisms, through which pathways this acted. And after we identified the Frizzled-4 gene, credit needs to be given to Jeremy Nathans, who played a major role in elucidating the pathway. So we now know that Frizzled-4 is part of the Wnt pathway, but it's not a Wnt. One of the Wnts that binds to Frizzled-4, it's actually Norin. So Norin is the ligand to the Frizzled-4 receptor. LRP5 is a co-receptor, and TSPAN12 is also sitting on the cell membrane and facilitates the aggregation of those units to potentiate intracellular signaling that results in release of beta-catenin. Intracellularly, beta-catenin then translocates to the nucleus, where it influences gene expression. And as far as ZNF4 408. Nobody really knows how it fits in there. And KIF11 acts through a completely separate pathway that I'll show you later. So, well, actually, I'm about to show you, this is the disease that's caused by KIF11, MLCRD, which stands for microcephaly, lymphedema, chorioretinal dysplasia. And the lymphedema is not something that's quite obvious in most patients, at least the ones that have been described and the ones that I've seen are that actually don't have lymphedema, but they pretty much all have retinal dysplasia and microcephaly. And it was first described as an autosomal recessive disease in a Mennonite pedigree by Victor McCusick. But most authors after that, especially in the 80s, described this as a dominant disease with a very variable phenotype. And KIF11 is part of the kinesin superfamily, and its function is localizes to the spindle microtubules during mitosis and is required for mitotic progression. There is a significant phenotypic overlap. In a couple of slides, I'll show you some examples, but the major clues are the presence of microcephaly, which is not obvious because we usually tend to focus on the eye. You actually have to step back. And with a kid with a full head of hair, you actually have to take a measuring tape out. Some of them are obvious, but the microcephaly is actually quite variable. The other clue is the presence of chorioretinal atrophy that you don't see as much, as you don't really see in fever. There are cognitive delays that can be present and be quite, again, quite a range of severity. One of my patients was sent to me because she had poor visual behavior and they thought that maybe she had retinoblastoma, but what they were seeing was the white patches of chorioretinal atrophy popping in and out of the red reflex. And her mother, and she had microcephaly. She had such severe microcephaly that I asked for a measuring tape during the EUA. There was somebody had to go scrounge for one in the OR. But her mother had mild microcephaly, and they thought it was just like familial microcephaly because mom had that. But as it turns out, mom and her mom did not have eye disease, but the maternal uncle had been institutionalized with severe delays, cognitive delays, and blindness. So I think that's the full range. Now, I don't have proof that the uncle was the great uncle had the same disease, but I do have maternal grandmother confirmed with the same variant as the granddaughter. So knowing this, it's important to be on the high alert for this particular cause of a fever-like phenotype, especially for genetic counseling and family planning. In the case of my pedigree, my family, they actually decided not to have other children after that, after knowing this could be the range of disease. And it's important because in our cohort, it was actually present in 6% of patients that were sent to us as potential fever. And then after we reported that, this was confirmed in other cohorts, especially the large cohorts in China. So there is significant overlap. That's what this suggests. And so whether it's a fever gene or not, I think it just needs to be in your mind that you want to make sure that you get molecular diagnosis to rule this out. And so that's what it looks like. That's my patient that was sent to me to rule out retinoblastoma. And so once I figured out that some of our patients had the KIF11 variant as the cause of their disease, I went back to her and did a fluorescein angiogram. And sure enough, she had a significant area of peripheral non-perfusion and those vessels that take on a circumferential course just ahead of that area of non-perfusion. And there's a nice patch there of chorioretinal atrophy where once during red reflex testing, you would see the white go flash on and off. And this is a range of features in our cohort. So you can see that most of them have significant chorioretinal atrophy, but the patient in the middle has just a few patches, and you could say maybe it's scar tissue from like severe, a retinal fold, severe dragging. It's not impossible. And if the kid really is a little older, not too much microcephaly, you could easily miss it. So it has to be at the forefront of your mind when you have a new patient with this disease. So that reiterates. And then there's a patient there from Elias that shows you the range of the chorioretinal atrophy and retinal dysplasia that you can find with this disease. So while all this was happening, other reports were emerging with describing ocular features that overlapped with fever. Some of them were syndromic, some were not. And there were also some good candidate genes in animal models that made us think, okay, if the diagnostic rate is so low, less than 50%, not just in our cohort, but reported by other authors, And then at the same time, in 2022, there was the publication of the recommendations from the Clinical Genome Resource Sequence Variant Interpretation Working Group that developed the gene and disease-specific refinements of the ACMG interpreting sequence variants guidelines to increase uniformity and consistency of the expert panel recommendations. So we thought, what if we reevaluate all of our variants from day one, because this now was 20 years into this program, the disease gene discovery program, and reanalyze them using these criteria, but also because of the low diagnostic rate, expand the FEVR panel for those for whom we had whole exome sequencing to include 19 genes that were previously associated with ocular features, and see maybe if that could increase our yield, because maybe some of those rare patients are missed because we're not looking into those rarer genes with a phenotypic overlap. And that was the work from that Sarah did. And we were looking to detect disease-causing variants that were either likely pathogenic or pathogenic. And a molecular diagnosis was possible in only 42, but roughly 41.5%, roughly 42% of patients, so still quite low. And none of them had any variant in the non-fever genes except for KIF11. About 90% roughly had a single disease-causing variant. Recessive disease was quite rare. And of the 41 total disease-causing variants in the 39 solved probands, about 80% were in 4 of the 6 recognized fever genes, and the rest were in KIF11. So applying the SVI criteria in our particular cohort was actually important because it actually downgraded 5 of the variants from likely pathogenic to VUS. And that would change in a clinical genetic testing environment. It would have changed the diagnosis from recessive disease to autosomal dominant disease with a potential for recessive disease because there was VUS identified in 2 of the patients. In one of the patients, it would have made us think that the disease was digenic. And then in 2 others that were deemed solved were now unsolved. So it's important to apply these criteria because over time, as things change, if we change VUS to a likely pathogenic or pathogenic variant, we know exactly what changed, what was the evidence to support the pathogenicity. And the role of the rare fever genes and candidate genes does require further study. We do need to improve the molecular diagnostic yield either through gene discovery or functional studies of those variants that are considered VUS. Variants of uncertain significance. So I'm going to switch gears now to retinopathy of prematurity because it was such a prominent part of the description of the initial papers on fever. And because there might be a bit of overlap with fever, even though it's a non-hereditary disease. And the risk factors for retinopathy of prematurity are numerous, but we knew before the fever genes were discovered that genetics might play a role in the course of the disease. So if you're looking for an association between a non-inherited disease and a genetic cause, there are different approaches that are used. You can use a candidate gene approach or a genome-wide association approach. They're association studies. They don't give you information about what's happening at the cellular level. And for each of those, there are pros and cons, but it does give you a clue to pursue. We were interested, and not just us, a lot of authors, once the fever genes were identified, jumped on the opportunity to look at cohorts of babies who had severe ROP versus those who had mild to no ROP to determine whether there was an association using the candidate gene approach. And as you see, it was all over the map. For the Nori disease gene, there were some that described an association, some not. For Frizzled-4, same thing. LRP5, there was evidence for possible association. I didn't see a report that did not identify one. So the ELS, that's Anna ELS in 2010 for Frizzled-4. When we discovered the Frizzled-4 gene, we jumped right away to see if there was a potential association with severe retinopathy of prematurity. And we found some interesting features that Emily Drenzen in 2009 put more evidence to support a potential association. So this was at the time our cohort of for the whole fever program. We had a branch where we wanted to look at ROP, and that included babies from Halifax, London, Ontario, and Calgary. And we had two groups, one with severe ROP and one with mild to no ROP. And we found 3 variants in the patients with severe ROP, but one we weren't able to put forward as a potential association because it was in a Vietnamese patient. We did not have, at the time, a Vietnamese cohort to determine whether this was a common polymorphism or a true variant, but it was rare in general, and at least the population that was mostly Caucasian. But so we were only able to put forward 2 variants, but that represents 3% of that group, and there were none in the mild to no ROP group. And even if you have a small percentage that shows an association, that's still important because there could be potential for mechanism action overlap between those diseases that are inherited and those that are acquired with similar phenotypic features. One interesting thing that we found was that 10% of babies had greater incidence of this polymorphism combination of P33S and P168S. It is sometimes found together and sometimes found separately in Caucasians especially. And it was rarer than in the general population in the group with mild to no ROP, but it wasn't statistically significant. Maybe our numbers were not as great. We weren't able to recruit as many babies with mild to no ROP to make that statistically significant. But when we looked at the time at the known fever gene variants, our 2 fever genes are in red, are located in areas that are not functional domains and unconserved. And then there are only 3 other genes, 3 other variants in Frizzled-4 that have the same location in an unconserved area and not in the functional domain. Every other fever gene is either in a conserved area or a functional domain, which made us think that maybe hypomorphic alleles might confer a predisposition towards getting more severe ROP in the context of premature birth, but if you're born full term, it's not severe enough to cause the disease. And then Kimberly Drenzer was able to look at this polymorphism in a larger group and identify significant difference between in the occurrence of this polymorphism in those with more severe ROP. And she went further, her and her team, to demonstrate that those babies who had this variant at a significantly lower birth weight, and when they did functional studies, showed that in comparison to wild type, it reduced intracellular signaling by about 80% compared to a variant, a C117R, that was their comparator. That variant causes fever. And so to cause fever, you have to have even lower function. So that was more evidence to support a potential link between Frizzled-4 variants. So we wanted to put a little more extra. We were working with the Frizzled-4 with a few fever mouse models, but we did have the Frizzled-4 mouse models. And they were thought at the time, the heterozygous mice, they were reported as normal, but I put in quotation marks when we look more closely, they actually weren't normal. I'll show you that. So we wanted to see if we put those heterozygous mice in the ocular ischemic retinopathy chamber through the protocol, will they exhibit worse disease than their wild type litter mates? Could a fever gene variant alter the course of ROP is really the question. And so demonstrating overlapping mechanisms of action support the theory that developing a therapy for one may actually influence the other. So Mike Noe was our postdoc who worked on this. And as you can see, the Frizzled-4 wild type in the bottom row, so you get the Gestalt view in the top row of what looks like the retina flap mounts at P12 in a Frizzled-4 wild type, Frizzled-4 heterozygous in the middle, and on the right, Frizzled-4 knockout. And then if you blow this up, you can see that in the middle diagram that the peripheral retina vascular is not quite the same as the wild type, but although much better than in the knockdown. So we put these mice through we raised these litters in the chamber. And when we took them out at P12, there was no difference in vasoobliteration. So being heterozygous for Frizzled-4 doesn't make you more likely to lose vessels. Just so you know, if you for a mouse, actually it's not peripheral disease, it's actually central disease. When you put them through the chamber, they lose what they had developed in the middle, and then they regain it afterwards. You just follow them over time. So at first they lose vascular areas centrally, then they get the neovessels, it goes away, and then this revascularizes. I should put that parentheses in place. And then in P17, when we followed them a little later, we were able to show that there's no difference between those between the neovascularization between those who were heterozygous and those who were wild type, but we did show that there was a delay in revascularization. They had a significantly larger area in the middle of vaso-obliteration than the wild type. And so that made us think that maybe the mechanism of action would be that hypomorphic alleles in frizzled 4 can influence the course of ROP by prolonging the period of vulnerability during which complications could happen. So it's a hypothesis, but it's a good one. So now I'm going to move to a completely different topic. We were also interested in developing therapeutics and thought if we use a zebrafish and create a zebrafish knockdown or knockout, could we use those to for a medium throughput assays? We had libraries of compounds that are easy to throw into the fish tanks and identify potential candidates that might be useful for treatment. So zebrafish, you may or may not know, are used commonly in new gene discovery by knocking down using various techniques, morpholinos, talons, early on in the development and showing a phenotype that somewhat makes sense compared to what you'd expect, knowing this, depending on the disease you're interested in. So we totally expected to find a phenotype by creating frizzled 4 knockdown early on, and usually you see that within the first few days of post-fertilization in the zebrafish. But we were quite surprised to see that actually at weeks 1 and 2, there was absolutely no difference between wild type and frizzled 4 knockdown. So we thought, And then we waited a bit, and at 3 months, though, found that inferiorly, in the ventral section, there's actually quite a bit of disorganized retina vessels in the frizzled 4 knockdowns compared to the wild types. So we thought, what's going on between weeks 2 and 3 months? Where's the earliest that we identify a phenotype, and what would it take to use the zebrafish as a model? So Lucia Caceres did this work, and I showed you earlier, this was Jason Berman's lab, who's now VP Research at CHIO. He used to have a big zebrafish facility right across the street from the IWK where I work, and Lucia was his master student. And zebrafish are pretty small, if you can think of enucleating zebrafish eyes. She did a lot of good work. So she was able to show that between weeks 1 and 5, there's no difference seen in the pathology. And the pathology starts to show up around weeks 6 or 7 as disorganization of vessels. And what happens is the vessels look like they're fused early on, and then they separate. And they look fused even in the wild type, but then they separate. But in the frizzled 4 and knockdown zebrafish, they're fused, but also a bit disorganized, and they stay disorganized. It's like the disease even gets more and more prominent peripherally. And so week 12, there were obvious pathology, and it was stable from 32 weeks onward. So there was no peripheral avascular retina in the zebrafish. And so then we had to think, okay, let's go back to what's known about the embryology. We were the first to describe retinavascular development in zebrafish. Anything that had been described as retinavascular development was only in the first week. And so this was all new. So what happens is it's the development in embryology for humans. The primary vasculature is actually the hyaloid system that wraps around the lens in the anterior, to feed the anterior segment. And then when that regresses, this is when the retina vascular development starts, and there's regression of the hyaloid as the retina vessels develop. That's not what happens in a zebrafish. In a zebrafish, you get the same primary vasculature that wraps around the lens, but the lens and the retina are fused together on the top image. And then after that, the retina separates from the lens and takes with it the vessels that wrap the lens. And so there's no peripheral avascular retina. And what happens is as the retina in the eye grows, the vessels start to grow in between, but there's never any peripheral avascular retina. There's no delayed regression of hyaloid because the hyaloid becomes the retina vessels. And so that's why it's important to understand those differences, because now it makes you wonder, is there a role for gene discovery? I think there probably is, but if you don't see anything, don't give up. That was the take-home message. And then could there be a role in therapeutic development? Well, Jason moved his lab, but I think there is, if somebody gets really good at dissecting those eyes, because Lucia showed that it was possible to do that. So that's as far as we got with this one. I'm just going to finish up quickly with the development of therapeutics that involved a lot of our trainees. And going back to our mice, there was a report that demonstrated that mice who were knockouts of S1PR2, sphingosine-1 phosphate receptor 2, who were put in the ocular ischemic retinopathy chamber through the protocol, did not develop as much retinopathy as wild type. So it seemed to protect against disease in a retinopathy of prematurity model. It turns out that and the reason why they did that is because sphingosine-1 phosphate receptors 1 and 2 are important in vascular development because they influence endothelial cell migration and proliferation. And then during embryology, there's always an interplay between organogenesis and inhibitory factors that keep themselves in check to develop organs, and it's the same for blood vessels. S1PR1 is responsible for promoting vascular development, and S1PR2 inhibit. And so because they're receptors, if you can inhibit the receptor of the vascular inhibition, so you're inhibiting the inhibitor of vascularization, for a period of time, could you not help promote vascularization for a short period of time because of delays in vascularization caused by FEVR gene variants? And so we thought, well, what if we breed together our FEVR mice with the sphingosine-1 phosphate receptor knockout mouse? And in the middle, you can see with the T-span 12 mice look like their retinas compared to wild type, and I'm not sure, this is probably not P12, it's probably a little earlier. And compared to the those that were double knockouts, you get restoration almost of the vessels. We didn't publish this because it was really hard to breed those double knockouts. They were very fragile, and the frizzled form, we weren't able to do it. So we moved on and say, okay, we did get a few retinas. We were able to show that there was, something promising. And so there's a compound called JTE013 that's a specific tool compound that inhibits, that binds to S1PR2 and inhibits the inhibitor vascularization. And injected intraperitoneally in frizzled form mice, we were able to demonstrate that you get quite an improvement in the phenotype. Now, this is the best one that we have. There is a range. And so we tested more mice, and in the middle, you can see the range of improvements. But by and large, for several of the parameters of vessel, the development, the vessel measures in the mouse models, we were able to demonstrate a statistically significant improvement. And so this just got accepted for publication 4 weeks ago, and it just popped up now, I think last week. And so in conclusion, developmental retinal vascular disorders are diverse with significant phenotypic overlap, highlighting the importance of obtaining a molecular diagnosis to improve family planning, prognosis, surveillance, etc. But we still need more research to improve the diagnostic yield. Norrin frizzled 4 signaling remains the most important fever pathway in 90% of patients who are diagnosed with fever molecularly. Polymorphisms and hypomorphic fever gene alleles may alter the course of ROP. There's some evidence to support that. And there's also evidence to support that finding a treatment for fever may help prevent ROP complications. And we have been able to demonstrate, there's other, I'm not 45 minutes, I focused on our stuff, but there's evidence to support that treatments are may potentially ameliorate the vascularization initially to prevent further complications down the line, and that may be potentially applicable to ROP because it's the same kind of thing that we try to do is prevent complications. And I made it 8:24.
So any questions? Sorry, I'm just online as well.
Did you need to take this down?
Actually, I got to do that.
Yes, it's done. I don't.
Yeah.
I'm not gonna need to.
So you're not going to use anything?
No.
Any questions from the floor? So I mean, obviously quite interested in ROP as you are. So do you think that sort of we have a lot of anti-VEGF treatments for ROP? Would you like to say if that will ever be important in fever? Because I guess we always see it when it's a bit more sort of a fibrotic, so you may not want to use it, but is there a mechanism that we could use, as our overlap with ROP bolts?
Yeah, it's not as black and white for sure with fever as it is in ROP. And even for ROP, it's not the be all end all, but it's certainly a game changer compared to what we had before. So there's definitely room for improvement. And for fever, there is a use, but with caution. And when you have the conversation with the families, you need to explain that there's a bit more variability outcomes when you use this, and you have to be selective in identifying the babies who are most likely to benefit from that. So I think there's a role, and it's been shown in publications that there is a role, but not quite as black and white as there is in ROP. And for both, there's still a significant need to improve our ability to treat these babies. For ROP, anti-VEGF agents can be game changers, but there are babies who are extreme preemies who still remain with such significant peripheral non-perfusion that they end up with complications despite our best efforts. And so if we could promote vascularization to the point that the complication risk would be less, that would be, I think, the next game changer. And I think there's still going to be a role for VEGF, but it might be in conjunction with other agents that promote vascularization during the postnatal age. There's a short window because we know from ROP that at some point there's no further vascularization. After a few months, maybe after a couple of months, this would not work. The big problem for us to move this forward to a clinical trial is that there's no natural history study for people. Fortunately, you need to know at birth, there need to be genetic screening for fever gene variants for us to know what happens. How does it look like at birth? The natural history, we don't have that. We see them after they've had the complications, but this treatment that we're proposing should happen before these complications happen. I think there will be a role. There's research happening to start doing genome sequencing methods with screening, and I think it's going to happen in onion peels. Like they're going to start with the diseases that are most actionable, like retinoblastoma. I think got put on the actually I know it got put on the list in the UK and maybe other areas, but certainly in Europe. And as part of the, seeing whether the pathway works, identifying the gene variants and get better outcomes and so on and so forth. And I think once that's been demonstrated to work, then it'll move to other genes. I think that fever could be the second tier. And that's only then that we'll have natural history studies that will enable us to do clinical trials with this. But in the meantime, it's fine. We can just find as many potential treatments as possible. I don't know a way around it right now. But maybe Brenda knows a way around stuff.
So whilst I'm going to look at these questions.
I have another question, which might be directing in the same direction. You have a molecule that does something amazing with the frizzled double knockouts. In a mouse. And a zebra to fish too.
So we haven't tested the zebrafish because Jason moved his lab. We still have the Aquatron lab, but we don't have a dedicated team of trainees. And Jason, I was working with teams. This is all related to me because I talk to people, but I don't get to do this. I get to analyze the phenotype because that's what I do. I phenotype people. So I learn about models, and then I learn about the zebrafish and so on and so forth.
My question is the drug.
Yeah.
Where did you get that molecule? Where did that come from? What's that really designed for?
So that had been described as an
evidence for whatever it does.
I think it was used for MS initially. So there was actually a description of that drug as a drug that could be used for that was known to be a sphingosine-1 phosphate receptor antagonist. We also used the cheminformatics drug discovery lab at Dalhousie to see if we could identify other compounds. We have other compounds in the pipeline, but we use this one because that one had been shown to potentially influence disease for MS, but it's still not out as a treatment for anything.
So is there a company that owns that drug? Or is it a research product? And if it's a company, how do they relate
that owns that drug? And there was no patent for that to be used for treating retinal vascular disease. It was neurological stuff.
So how do you move forward from this position to get a drug that you can actually use clinically and put into a clinical trial?
That's the $1 million question.
How do you get industry
So
interested
we
in?
tried to get drug companies involved and interested. We haven't been able to do that. And the big barrier for fever, because we thought with rare disease, there's an easier pathway to get clinical trials started, but you need to have the natural history study component, and we cannot do that until we have neonatal screening. So in the meantime, we're putting this out there. If I retire and it takes 10 years for that to happen, at least somebody can take it and do something with it once it's possible to do that. But we haven't been able to get a drug company interested. We've been trying for 10 years.
Rare diseases they don't care about because they don't make it money on them.
Exactly. And then I said, well, what if it helps diabetic retinopathy? You inhibit it. So they said, well, no, we're into treating diabetes, not diabetic retinopathy. Okay. We've tried several times. Nobody bit.
Joanna, thanks, that was brilliant. Also for Tamiar, there's some very recent work that I just saw online within the last week or two about using topical steroids to control ROP.
I didn't see that.
Therapeutically, I don't know how much that is going to go, where that's going, but it was something
This week I
online.
was busy.
I know with Tamiar,
But actually, I don't know anyone. I didn't see that.
Yeah.
is that something potentially that, or is it?
That's the work that's come out of Sweden, basically. They think there's a inflammatory role in that acute phase that helps in revascularization. The studies are not very well done.
Okay.
It is the evidence level for that is not very high, although they have shown it. The control arms and the pattern they use is over different times in different regions, and it was one person started doing it, and then they found controls from other years in other groups. So we actually did it in our ROP journal not recently, so kind of know a bit about that. But it's not high level of quality yet, but there might be a role for that.
I just wondered if there might be a role in.
Yeah, exactly. So
Sure,
it might be a
that's the same.
combination of things, right?
Yeah,
That depending on what the mechanism of action is. But I mean, for steroids, moms who are given prenatal steroids, the babies tend to do a bit better. So there's a bit of evidence to support that maybe there's something there, but maybe further study.
And there's, if you have 1 second, there's Elise is asking online, Dr. Ian, whether there's any role that we should be doing genetic testing in ROP to kind of basically outcome prediction is the best way to.
Yeah, exactly. I think it'd be really interesting to do a study and repeat those candidate genes studies that it can be broader, include the main fever genes for one thing. But that would require research to demonstrate a role for that. And that would be a good study. That would be a great idea.
And problem is over the years, neonatal care changes, and there's so many other variables that,
Yeah, you can't go back.
Too much noise in the system sometimes.
Yeah, and you can't go backwards. It's got to be done in the moment because medical care has changed, and ROP doesn't look like what it did when I started 28 years ago. It looks totally different. And it looks different in different parts of the world. So you really would need to do this prospectively.
Great. So I think we're running out of time, so we should wrap it up. Thank you again, Dr. Our invitation, and our residents will have a 3-hour chat with cases and amblyopia coming up. So thank you very much for all that. All right, thank you.
Pleasure. Yes, that's teaching.